sir.
Okay, thank you. Thank you for the opportunity. Thank you, AIOS, and thank you, Dr. Saurabh, for giving me the opportunity to present this CSR patient having cataract. What to do? What is CSR? A common cause of visual impairment in 20 to 50 years. There is accumulation of subretinal fluid. All we know that in the macula, there is accumulation of subretinal fluid and which is associated with corticosteroid exposure, phosphodiesterase inhibitor use, obstructive sleep apnea, and type A personality. And maybe nowadays we know that in the spectrum of pachychoroid. So types of CSF that may be typical, what we commonly see a central dome-shaped detachment of sensory retina, or atypical. It might be bullous, it might be with subretinal fibrin, it might be with exudative retinal detachment, it might be with RPE epithelial tract. How to manage? So typical natural history is spontaneous resolution, but 20% patient, there is persistent subretinal fluid. And if fluid persists more than 3 months, that needs treatment, and which termed as chronic CSCR. All we know that. And if the fluid persists more than 6 months, some degree of vision loss is inevitable. So it is plausible that the retinal degeneration which ensued from extended neurosensory detachment could cause permanent vision loss unresponsive to current treatment modalities. Early diagnosis of CSR as well as appropriate timely treatment are important in preventing degenerative changes and optimizing visual outcome. So this is a patient. This patient had choroiditis earlier, and the patient developed and CSR. So the steroid stopped earlier, but there is multifocal leakages noticed, and this is chronic CSR, and there is intraretinal cystic changes, subretinal fluid, and there is fibrin. So what we did, we put green laser, and this is the outcome. So if this patient develop cataract, how to manage? This type of patient, we need to see his or her visual potential before cataract surgery. Why? We need, what we need is an OCT before cataract surgery to know that the status of the fovea. And if the cataract is much more, then we need old prescription to know what is the past vision before that cataract sets in. That is a good hint of the post-operative outcome. Retinal acuity meter, wherever possible, whenever available, can guide us what is the most probable outcome after cataract surgery. Good preoperative counseling. This is 1 to 10. I would suggest that good preoperative counseling is mandatory in this patient because all the patients have the expectation that after cataract surgery I can see fine, but preoperatively, if we counsel this patient, okay, see your retina is damaged and you can see well after cataract surgery, but not that as much as you expected. That is very good for post-operative, any odd behavior from the patients and happy patients, for happy patients. And if possible, avoid cataract surgery in presence of fluid. So this is one of my patients with the CSR from 2017. Then how to manage? A good phacosurgery can give maximum visual outcome. All we know that. Surgery should be minimally traumatic. Minimum postoperative steroid or no steroid. Minimum postoperative steroid or no steroid if possible. Topical NSAID instead of steroid. And postoperative OCT to check any new accumulation of fluid. So this is my patient with bilateral CSR in atypical type and with RP epithelial tract. And this is his OCT in 2017 till she follows up